Coming up in this episode, I think that's taking it a bit far. It's probably throwing the baby out with the bathwater to some extent. So I would suggest that it's still important to do your best to carefully clarify what is meant by dizziness, especially if the patient can give a clear description of either vertigo or of presyncope. But the point that I'm making here is don't over rely on the way that the patient describes dizziness to you, especially if the patient finds it really difficult to describe. And there will be times when you will see patients and you say, "What do you mean when you say dizzy?" And they'll say, "I don't know, I just feel dizzy." And you'll say, "But what do you mean?" And they'll say, "Stop asking me that. You've already asked me. I just feel dizzy. I don't know how else to describe it." Or maybe the patient is elderly or confused or they're vomiting and they're not having a good time, and you just cannot, for the life of you, really nail down whether they are describing a vertigo or a presyncope. And that's okay. Sometimes that happens, and we recognize that it can be difficult. And so that's where you need to rely on your examination skills. Hello, and welcome to the latest installment of Risfeld Neurology Education, a not for profit, free open access project with a philosophical touch, exploring all areas of clinical neurology. It's meant for medical students through to neurologists and all health professionals caring for patients with neurological conditions. I'm your host, Tom Risfeld, a neurologist, epileptologist, and neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. Today I'll be presenting the next episode in the neuro-otology and vertigo series titled Approach to the Dizzy Patient and Overview of Causes of Vertigo. And before we begin, a legal disclaimer. The content of this episode is for educational purposes only. So let's dive into it. Dizziness, one of the most common reasons for emergency department and outpatient presentations. But it's important to determine exactly what the patient means by the word dizziness. So, vertigo is the term that we use to describe a symptom of illusory movement. So, spinning, rotation, swaying, tilting, and it can be either movement of the environment or the perception of self motion or a feeling of the head moving, the head spinning. So, some of the ways I describe it to patients is as if you've been spinning around on the spot and then suddenly stopped, or like you're on a rocking ship in high seas. So, that constitutes vertigo. There's a closely related concept of disequilibrium. So, this is a sense of unsteadiness and imbalance, primarily experienced when walking. Disequilibrium is a bit less specific, so it can be secondary to pathology of the vestibular system, so peripheral or central components of the vestibular system, or it can be also secondary to other causes, so a peripheral neuropathy, or it could be owing to musculoskeletal issues interfering with gait. So it certainly can be neurological, but it's less specific and it might not be. And then thirdly, there's the concept of lightheadedness, which is essentially pre-syncope. And that can be either vasovagal or cardiogenic or metabolic, such as in the context of hypoglycemia. And really, we break this down into cardiogenic and non-cardiogenic pre-syncope. And presyncope and syncope are not secondary to pathology affecting the peripheral or central vestibular structures. So, as I mentioned, it's really important to try and tease out what the patient actually means when they say dizziness. So, are they actually describing vertigo? Are they describing disequilibrium? Or are they describing lightheadedness or presyncope? But one important proviso here is that a patient's description of what they mean by dizziness, even when you do your best to tease it out, can be notoriously difficult to establish and it can be unreliable and it can lead to diagnostic error if it leads you down the wrong path. And I've just included a screenshot of a title and the names of the authors that were involved in a paper which evaluated this. And some people have gone to the extreme and concluded, well, it's not even worthwhile trying to ascertain what the patient means when they say dizzy because you just need to do your workup anyway and you have to rely on your examination signs rather than on the history, rather than on the patient's description of dizziness. I think that's taking it a bit far. It's probably throwing the baby out with the bathwater to some extent. So I would suggest that it's still important to do your best to carefully clarify what is meant by dizziness, especially if the patient can give a clear description of either vertigo or of presyncope. So I don't think that's having your cake and eating it too. I think if you ask the patient what they mean by dizziness and they give you a beautiful description of, oh, it's like I'm on a rocking ship, it's like the whole world's spinning around me, all these objects keep moving around me, that's a pretty clear description of vertigo. Conversely, if the patient describes, oh, I feel lightheaded as if everything's going black and I feel like I'm about to faint, but there's no rocking or spinning component of my environment or of my head, that's a pretty clear description of presyncope. Or if they're saying, I just feel really unbalanced and unsteady on my feet, that's more consistent with a disequilibrium, although as we've discussed, disequilibrium is less specific and can go either way in terms of the underlying etiologies. But in any case, if the patient gives a really nice, clear description, I think you can be guided by that, at least to some extent. But the point that I'm making here is don't over rely on the way that the patient describes dizziness to you, especially if the patient finds it really difficult to describe. And there will be times when you will see patients and you say, what do you mean when you say dizzy? And they'll say, I don't know, I just feel dizzy. And you'll say, but what do you mean? And they'll say, stop asking me that. You've already asked me. I just feel dizzy. I don't know how else to describe it. Or maybe the patient is elderly or confused or they're vomiting and they're not having a good time. And you just cannot, for the life of you, really nail down whether they are describing a vertigo or a presyncope. And that's okay. Sometimes that happens. And we recognize that it can be difficult, and so that's where you need to rely on your examination skills. So there are some helpful additional symptoms that are good to ascertain before you dive into the examination, however. So it's important to know if the patient has nausea or vomiting because that's common in patients with vertigo or disequilibrium. You can, of course, have nausea and vomiting in presyncopal states as well. Maybe you've got a metabolic problem and you're hypoglycemic, but it's still useful to know. Also, you may hear the term oscillopsia thrown around a bit. So that's a description of a visual to and fro environmental motion with head movements. Then there are also other relevant associated symptoms which may hint at the underlying etiology. And I mentioned some of these when I was talking in the previous neuro-otology episode on the hints examination, but I'll go over some of them again because they're good to be mindful of. And the important point here is they may lead you in one direction or the other, but there are always exceptions, so you do need to keep an open mind. So, ask about infective features. Does the patient have fevers, a cough, coryza? That could, for instance, suggest a vestibular neuritis. But there's always exceptions. So you can have fevers with infective endocarditis or with CNS vasculitis, and both of those can cause stroke. So keep an open mind. Are there any oral features, as in AURAL? Are there any ear-related symptoms? So that's hearing loss, pain, tinnitus, fullness, or discharge from the ear. So that could suggest, say, a Meniere's disease in the context of the hearing loss and the tinnitus, or vestibular neuritis with labyrinthine or cochlear involvement, or it could be an ear infection, especially if it's painful with discharge and fullness. However, it could also be a stroke, so especially if it's involving the ACA territory, the anterior inferior cerebellar artery territory. And that's what the plus in the HINTS Plus examination acknowledges. So if you listen to the episode on the HINTS Plus examination, you'll hear all about that. Thirdly, it's good to know about headache. Headache is an important symptom in neurology, and it's definitely an important symptom in assessing the patient with vertigo. So headache plus vertigo could suggest migraine with vestibular features, or some people might say vestibular migraine. That's a bit of an outdated term, but I think everyone understands what is meant by vestibular migraine or migraine with vestibular features. But again, there's always exceptions. So you could have a hemorrhagic stroke that could certainly cause a headache, or a subarachnoid stroke is a form of a hemorrhagic stroke. Or you could have an ischemic stroke, which is coming on from a cerebrovascular dissection in the posterior circulation. So a vertebral artery dissection with neck pain radiating up into the head. So again, keep an open mind. And then to state the obvious, any lateralizing weakness or sensory loss in the limbs or visual loss or dysarthria, dysphagia, upper or lower limb ataxia, they're all major red flags for a central cause, whether that be stroke or some other central cause for vertigo. So, what do you do after you've established that the patient has or might have vertigo or disequilibrium? Well, you then need to determine whether the vertigo is either acute sustained vertigo, so that's what we call an acute vestibular syndrome, or whether it's episodic vertigo, so whether it's coming on in discrete episodes. Is it coming and going, coming and going? And if that's the case, you then need to know whether it's triggered or non-triggered. So is there an obvious triggering factor for the episodes, or do they just come on out of the blue with no identified trigger? One important trap that people often don't recognize is that essentially every cause of vertigo, irrespective of whether it's from BPPV, benign paroxysmal positional vertigo, or some other cause of vertigo, will to some extent be worse with head movements. So that's certainly true for BPPV, where that's the hallmark feature, where it's a triggered episodic vertigo in the context of head movements. But in BPPV, there should be no vertigo at risk, and it should be consistently triggered with the same transient vertigo with the same particular head movement or head movements. Whereas essentially all the other forms, or all the other causes, I should say, of vertigo, if they're episodic or whether they're acute sustained vertigo, they're not going to be better with head movements. They're going to be worse with head movements, but they're not the same triggered, episodic, only present after head movements, go away without head movements. They're not that same clear-cut pattern that you get in BPPV. The other thing to recognize is that if someone has an index presentation with an episodic vertigo, then by definition, you don't know that it's episodic yet. If someone has their first presentation of Meniere's disease with vertigo, by definition, it's not episodic yet because it's only happened once and it's still happening. So you can't actually philosophically distinguish between an acute sustained vertigo, so an acute vestibular syndrome, and an episodic vertigo if you're seeing the patient for the first time in the first hour of the presentation and they've got the symptoms. There's no way to know. So that is a bit of an epistemological shortcoming, but it's a bit easier if someone already has an established diagnosis of Meniere's disease or some other form of episodic vertigo, or they might not have an established diagnosis, but you can ask about it historically and they say, oh, actually, yeah, the same thing did happen last week, and then it happened 2 months ago, and it happened a few years ago as well. Then you've established that actually this is an episodic process. It's not a one-off acute non-episodic process. So you've done your great history. Now we go on to the examination. So what I would suggest doing is certainly if the patient is presenting as an acute vestibular syndrome and if stroke is on the cards as a differential diagnosis, you've got to do a NICE exam, an NIHSS, a National Institutes of Health Stroke Scale examination. And please see our NICE video and audio podcasts for detailed instruction as to how to perform a NICE examination. After you've done that, provided that you're not going down a hyperacute stroke pathway, you then need to do a full neurological examination. And please see our cranial nerve and upper and lower limb neurologic examination videos for instruction on that. And then in addition, there are some additional specific vestibular examinations that you need to do. And that could include a HINTS examination, or a HINTS plus examination, I should say, for an acute persistent vertigo and acute vestibular syndrome, and please see our episode on that. And then if it is looking like a BPPV, so if it's a episodic vertigo triggered by head movements, then you need to do a Dix-Hall-Pike to look for posterior canal BPPV. And failing that, if that's not diagnostic, then you need to do a horizontal roll test to evaluate for horizontal canal BPPV, whether that be geotropic or ageotropic. And please see our episode on the vestibular examination for detailed instruction on the HINTS exam and on the Dix-Hall-Pike and the horizontal roll tests. So you've done your examination. Now let's talk about the causes of vertigo and how they're grouped and how you approach them. So We've spoken about acute persistent vertigo, and some of the main causes of that. We're not doing the exhaustive list yet. This is the main causes to begin with. You've got to think about vestibular neuritis, so that's your peripheral cause. You've got to think about a posterior circulation stroke, so that's going to be your main central cause. And then there are plausibly some other central causes as well, even in the acute context. So something like demyelination, you could have an MS plaque in the brainstem affecting some of the vestibular connections, for example. Usually the time course wouldn't be as sudden and as acute as you would expect for stroke, but weirder things have happened, so that is on the list as a possibility. Then in terms of your acute episodic vertigo, you've got triggered, and classically that's BPPV, which we've already spoken about quite a lot today so far. And then plausibly there could be some other causes as well. So you could plausibly at least have vertebrobasilar insufficiency, which may have a positional component to it. Although I will say that this is thrown around as a potential differential diagnosis quite frequently, but actual true confirmed cases of vertebrobasilar insufficiency are actually not that common. In fact, they're probably in the rare territory. And there have definitely been patients who I've seen who I've thought, oh, this does actually sound like vertebrobasilar insufficiency. They've got really nasty bilateral vertebral stenosis, and if there's a positional component to the symptoms, maybe they are getting transient position related hypoperfusion to their posterior circulation, and they're essentially getting posterior circulation TIAs, which are triggered by mechanical factors with positioning and kinking of the vertebral arteries and such. But often we end up doing CT angiograms and sometimes even more advanced radiological studies, and often that diagnosis isn't actually objectively substantiated. So it's something to think about, but more often than not, that doesn't end up being the diagnosis. There's also vertebral steel phenomena. So I should say actually a subclavian steel phenomenon. So again, that's a phrase which is thrown around quite frequently. It's important to know what it refers to. So that's when you have stenosis in the subclavian artery, which is proximal to the origin of the vertebral artery from the subclavian artery. And so when your arm needs blood, such as when you're doing things with your arm or when you're elevating your arm or such, it may be that the blood just isn't really getting through that area of proximal stenosis and actually getting down into the arm. So what can happen is sometimes the arm steals some blood from the vertebral artery, and there's retrograde flow through the vertebral artery down into the distal subclavian artery and down into the arm. And so that's sucking blood away from the brain because it's taking the blood flow away from the vertebral artery. Or it may also just be that the subclavian stenosis itself just isn't letting enough blood get through into the vertebral artery to permit antegrade flow up that artery to begin with. And that can also cause transient hypoperfusion in the territory supplied by that vertebral artery. Although you've got to remember that the basilar artery, of course, is supplied by two vertebral arteries. And in terms of the anatomy of the circle of Willis, most of the major branches actually come off the basilar artery, with the exception of the PICA, the posterior inferior cerebellar artery, which comes directly off the vertebral artery. So it's theoretically plausible that you could have some of these pathologies causing triggered episodic vertigo. But in reality, in daily clinical practice, such true cases are few and far between. Now let's turn to non-triggered acute episodic vertigo. So the main ones to think about are Meniere's disease, migraine with vestibular features, and plausibly, in a similar vein to before, recurrent or crescendo TIAs. But again, that would be pretty unusual because if a presentation with recurrent neurologic symptoms is stereotyped, then it's unlikely that TIAs or a vascular cause is the explanation, unless there's a specific cerebrovascular structural explanation as to why the symptoms would be stereotyped. So again, I'm not saying that it's impossible, and it is something to think about, but more often than not, that's not going to end up being the diagnosis. Now, as I mentioned, this isn't an exhaustive list, but let's go through these ones to begin with, and then we'll turn to some of the other rarer causes. So firstly, in terms of distinguishing vestibular neuritis from stroke, I did talk about this in the previous neuro-otology talk on the hints examination, so I'm not going to spend as much time on this slide, but I will just go over it briefly for the purpose of repetition for memorization. So vestibular neuritis can present very acutely and very severely. I've seen some patients with vestibular neuritis and they look crook. They are vomiting, profusely vertiginous, can't stand. They've got really, really profound acute vestibular syndrome symptoms. It's not a pleasant condition to have, and it really can mimic a posterior circulation stroke. However, in a patient who doesn't have other red flag features in the history or on the examination, and especially if they have a hints plus examination, which is suggestive of a peripheral etiology, then that patient is likely, very likely in fact, to have vestibular neuritis rather than stroke, especially in the absence of classic vascular risk factors, so previous strokes, known cerebrovascular stenosis, or hypertension, diabetes, hypercholesterolemia, obesity, smoking, etc. And in particular, it's really quite unusual for a posterior circulation stroke to cause isolated vertigo with nothing at all else. If you just think about the anatomy, the brainstem structures are so closely packed together, and a lot of the cerebellar connections are closely packed together as well, that if you get a posterior circulation stroke, which is affecting the vestibular system or the closely related cerebellar system, it's pretty likely that some other important central structures are going to be knocked off as well. And so it's likely that you're going to have some other deficits. I'm not saying it's impossible, but it's unlikely. And if you think about it at a more pragmatic level, in terms of hyperacute stroke management, that patient is then by definition going to have a very low NIHSS score, probably a 0 actually. And so that patient is not going to be a candidate for thrombolysis or mechanical thrombectomy anyway. Now, that being said, it is always good to discuss such cases with the neurologist on call if you're not the neurologist on call, because there is some variation in practice and some people may take a bit of a more conservative approach and choose to do a CT and a CT angiogram, plus or minus a CT perfusion, if there's any diagnostic doubt whatsoever, just because of the dire consequences of a misdiagnosis. And there are some tricky ethical and medico-legal implications as well. I won't go too much more into that now, though. So let's talk a bit more about vestibular neuritis in terms of the treatment and the prognosis. So we've talked about the diagnosis, we've talked about how it can be nasty. How do you treat it? This isn't an in-depth video or audio podcast on vestibular neuritis, but just an overview. So firstly, glucocorticoids, so corticosteroids of the glucocorticoid variety, may hasten recovery, although the effect on the long-term outcome is unclear or less clear. So the therapeutic dosing guidelines I usually go with in Australia is the Electronic Therapeutic Guidelines, the ETG, which is what we all use in Australia at least. And they recommend prednisolone or prednisone 1 milligram per kilo up to 75 milligrams orally daily in the morning for 5 days, and then a gradual taper of the dose over a following 15 days, and then stopping. So you're doing relatively high dose oral prednisolone for 5 days, and then a moderately fast taper over 15 days, and then stopping. State that adding antiviral therapy has no additional benefit. Unlike in severe cases of Bell's palsy, where we treat with prednisolone with a not dissimilar dosing regimen, it's not exactly the same, but similar. And in severe cases, there is a better body of evidence to support the use of antiviral therapy, but that's not the case for vestibular neuritis. Betahistine. So betahistine is not really evidence-based, but in my experience, most people give it a go anyway. So it's not unreasonable to trial some betahistine, but just know it's not really evidence-based. Antiemetics will be necessary and should be used as necessary. And it's important to recognize, as I mentioned earlier, that vestibular neuritis, even though it's benign in the sense that it's not a posterior circulation stroke, it's just a peripheral problem, it can be highly disabling and it can have a prolonged recovery time and it can require rehabilitation. And it really does also depend in part on how fit and how young is the patient who got the vestibular neuritis. So if you've got a fit, young, healthy 25-year-old who's had a bout of vestibular neuritis, I'd expect that patient to do better, all things being even. But if you've got a 7-year-old who's got heart failure and chronic kidney disease, and they're already a bit frail and they're already needing help at home, and they get a nasty bout of vestibular neuritis, and they already had difficulty walking because of their hip replacement and their chronic pain. I hope that I'm painting the picture here. If you've got someone whose functional reserve wasn't so high to begin with, that patient may end up needing to go to rehabilitation and may be more affected by their bout. And I was interested to learn, actually, when I was doing some research around this topic not so long ago, that about 30% of cases are reported in the literature to actually not make a complete recovery. So it's actually quite a nasty condition, vestibular neuritis. Now, moving on to BPPV. The history should really give the diagnosis away. So it is manifested by vertigo, which lasts for seconds, up to a few minutes at most, and it's provoked by head movements, and there should be an absence of other symptoms and signs which are suggestive of an alternative peripheral or central diagnosis. And it can be post-traumatic. And that can be tricky, actually, because then you might get multi-canal BPPV or bilateral BPPV, and they're more difficult to treat. In terms of the therapeutic maneuvers that are used to treat BPPV, please see the previous neuro-otology episode because I go into this in detail. But as a very, very brief summary, for posterior canal, you do an Epley maneuver. For horizontal canal, you do a barbecue roll maneuver, which is a Lampert roll maneuver. And that's especially effective for geotropic horizontal canal BPPV. It may be effective for ageotropic horizontal canal BPPV, but it may not be. If you've got a patient who has ageotropic horizontal canal and it's not responding to a barbecue roll, or if you've got a patient with anterior canal or multiple canal or bilateral BPPV, these cases are much more complicated and different, and quite complex techniques are required. And I think that you're in subspecialty neurology territory at that point. So I would be referring my patient, and I would recommend that you do the same. I would be referring the patient to a vestibular subspecialist neurologist or a vestibular physiotherapist at that point. Now on to Meniere's disease. So what is Meniere's disease? What's the etiology of Meniere's disease? So it's said to be an idiopathic endolymphatic hydrox. So what does that mean? Basically, it means there's excessive endolymph accumulation in the inner ear structures. And what does that do? It causes distension or distortion of the membranous portion of the inner ear structures. Now, there's a few postulated theories as to why the endolymph accumulates in the first place. So some theories state that there's abnormal flow and therefore abnormal clearance of the endolymph. Some say that there's hypoplasia of the vestibular aqueduct. Some say that it's an antibody-driven immunological attack against the endolymphatic sac. Some have identified that there are genetic factors at play and that there's an autosomal dominant pattern of inheritance in between 8 and 15% of cases. And that's why it's important to ask about a family history of Meniere's disease in a vestibular assessment. And some have also wondered whether there may be a common vascular pathophysiology with migraine based on some epidemiological associations. I'm not sure which of these postulated theories holds the most weight. They're all postulations, but they're all plausible in their own rights. The thing to remember is that Meniere's disease is caused by this excessive accumulation of endolymph. Exactly why that happens isn't completely clear, but it's likely to have something to do with the flow of endolymph, the clearance of endolymph, or possibly has an immunological basis, and at least 8 to 15% of cases also have a genetic basis, and there is also an epidemiological association with migraine. So this is quite important to know. How long do the episodes of vertigo in Meniere's disease actually last for? That's really important to know. So typically they last for between 20 minutes and 12 hours, but they can last up to 24 hours. So that's your range, 20 minutes to 24 hours, but usually it's 20 minutes to 12 hours. So what that means is that if someone has an episode of vertigo that only lasts 2 minutes, that's not Meniere's disease. That's something else. That's probably BPPV or something else. However, the disequilibrium can persist in between the vertigo attacks. So you can have proper established vertigo lasting for, say, 6 hours, and then in between attacks, you might have a chronic disequilibrium state that is still consistent with a diagnosis of Meniere's disease. Now, there are some important associated symptoms here. Importantly, hearing loss. And initially, it's only to the lower frequencies, and then it typically progresses to permanent hearing loss to all frequencies over 8 to 10 years in the affected ear, if not adequately treated. And there's also often associated tinnitus, so ringing in the ear, and an aural fullness. And in terms of the hearing loss to lower frequencies, that's going to be formally diagnosed with audiometry assessment. But it's interesting to know that that can sometimes be the opposite of age-related hearing loss or presbycusis, where sometimes patients experience difficulty with higher frequencies and they may find it difficult to hear people who have higher voices and may find it easier to hear people who have deep low voices. Strictly, the diagnostic criteria for Meniere's disease require there to be 2 or more attacks in order to make the diagnosis of Meniere's disease. So that means it needs to be proven to be an episodic condition. And audiometry and also formal vestibular function testing is very useful in terms of establishing the diagnosis, and really they ought to be performed. How do you treat Meniere's disease? So again, this is an overview video, but as an overview, there are non-pharmacological components to treatment. So there are dietary and lifestyle modifications. So that consists of a salt restriction, limiting caffeine and alcohol, and limiting triggers if other triggers have been identified. So if a patient finds that nicotine or MSG food supplements or stress is a trigger for their episodes, then do your best to avoid them as well. It's tricky with stress. Everyone has stress. It's hard to avoid stress, but you would still say it and you do what you can to have a non-stressful lifestyle. In terms of other treatment, vestibular rehabilitation for persistent disequilibrium between the acute vertigo attacks can be helpful. And what that does is it maximizes the central nervous system's balance center compensation for the peripheral disequilibrium, but it's not really helpful for the acute vestibular attacks. So that's more for the persistent disequilibrium. Antiemetics are really important, along with vestibular suppressions for acute attacks. So antiemetics including prochlorperazine, also metoclopramide and ondansetron. And in terms of vestibular suppressants, that can include transient use of benzodiazepines for your acute vertigo attacks. And then in terms of refractory cases, your first-line pharmacotherapy is going to be betahistine and diuretics, in particular hydrochlorothiazide. Your second line is going to be glucocorticoids, such as prednisolone, and that can be oral or it can be intratympanic with your ENT doctors. And your third line therapy, which of course would require link in with an ENT surgeon, procedural management. So that could be endolymphatic sac procedures, so decompression and or shunting of the endolymphatic sac to try and structurally deal with the problem of the excessively accumulating endolymph. And that's a procedure that you can attempt if the hearing is still spared. Conversely, if the hearing is already lost, then you can turn to more extreme or hardcore procedures which would have caused deafness, but the patient's already deaf or close to deaf. So that includes intratympanic gentamicin. So that's going to make the patient deaf, but if they're already deaf, then that's an option. And as a last resort, you can do a total labyrinthectomy, which of course would cause deafness, but it's an option if the patient is already deaf. Now let's talk briefly about vestibular migraine, or migraine with vestibular features if I'm using my words more carefully. So migraine with vestibular features causes an episodic vertigo which typically lasts from minutes to hours. Occasionally it can be fleeting, just lasting for seconds or minutes, and it can be a mimic of BPPV, but more typically it's more in the range of more than a couple of minutes and into the hours. It can be an extremely difficult diagnosis to make in so-called acaphalgic cases, so cases not actually associated with a headache. So we know that some forms of migraine can manifest with migrainous symptoms without the actual headache itself, and some forms of migraine with vestibular features can be an example of that. But in order to make a diagnosis of migraine with vestibular features, even if there are some acaphalgic examples, is that at least some of the attacks should be associated with a headache or with other typical migrainous phenomena. So a visual aura, photophobia, phonophobia, for example. Usually it is spontaneous, so non-triggered, although sometimes it can be triggered. So it could be triggered in some patients by foods or specific sensory stimuli or specific situations on a case-by-case basis. And the management is essentially as per the management for migraine. Now, to finish up, let's talk about some of the other causes of vertigo. So, we've spoken about the main causes. Now, let's be a bit more exhaustive and talk about some of the other causes of vertigo because you want to have a broad overview of all the possible causes so that you're not hearing about them for the first time and so that you're open to the idea of these diagnoses because the greatest problem in some senses is the unknown unknowns. So I don't want you to have unknown unknowns. I'd prefer you to have known unknowns so that you can at least go and look them up if you are seeing a patient who has vertigo and they are not meeting any of these classic categories and you think maybe it's one of these rarer causes of vertigo. I better go and look that up. And some of these you should really know about anyway. So firstly, Ramsay-Hunt syndrome, or herpes zoster oticus, in other words, involving the eighth cranial nerve. So that's reactivation of latent herpes zoster in the geniculate ganglion. And that can manifest with vertigo, plus or minus with hearing loss. But it also will or should manifest with a seventh nerve palsy, so with a lower motor neuron facial palsy, which will involve the forehead as well as the middle and the lower face, as we've discussed in our cranial nerve episode. And you may also be able to see vesicles in the auditory canal and on the auricle. So it's important to pull out your trusty otoscope and have a look. And usually Ramsay-Hunt syndrome is treated with glucocorticoids and with antivirals, so with acyclovir or valacyclovir. Nextly, there are some traumatic causes, so labyrinthine concussion, for example, following a head trauma, and that's especially a consideration if a patient's known to have a transverse temporal bone fracture. So if you've done a CT brain with bony windows and you've seen that there's a transverse temporal bone fracture, that should raise your suspicion that there may be trauma or concussion to the labyrinthine system itself. And that may manifest with hemotympanum, so blood behind the tympanic membrane or blood coming out of the ear, and with hearing loss. And it should be distinguished from post-traumatic BPPV, which could also come on after a head trauma, but rather than causing a bony fracture or direct trauma to the labyrinth, it's causing the otoliths to become dislodged and therefore causing BPPV. Next, you can get this condition called a perilymphatic fistula. So that can come on after a head injury, but it can also come on after barotrauma, such as scuba diving accidents, or it can come on after heavy lifting with a big valsalva and therefore a shift in intrathoracic pressures relative to the head. And the way that that classically manifests is episodic vertigo, which is provoked by shifts in pressure, so changes in your intrathoracic or intra-abdominal pressure, which is then in some way transmitted up into the head, and then these shifts in pressure is what causes the episodic vertigo. So if someone has vertigo when they sneeze or lift or strain or cough, or also loud sounds can cause some episodic symptoms in this case, then that is suggestive of perilymphatic fistula. And the management for that is either conservative management or it may require surgical management, so patching of the hole which is causing the fistula. In a similar vein, another condition is semicircular canal dehiscence. So that's when there's a thin bone only or absence of the bone which normally separates the semicircular canals from the other inner ear structures. And so it causes pressure to be transmitted too easily between the structures. So again, that can cause an episodic vertigo from coughing, sneezing, Valsalva maneuvers, loud sounds. And again, the management is sometimes conservative or sometimes surgical to fix that structural problem. And now the last slide of today's episode is some other rarer still causes of vertigo, and I'll just go over these briefly so that you're not hearing them for the first time, but we won't go into a great deal of detail for these conditions. So firstly, there's a condition called vestibular paroxysmal, which really causes very, very paroxysmal, brief vertiginous symptoms for 1 second or several seconds at most. There's a condition called Cogan syndrome, which has an autoimmune basis and causes Meniere's-like attacks. You can have a vestibular schwannoma causing vertigo, although that would cause a slowly progressive vertigo as opposed to an acute onset vertigo. You could have aminoglycoside toxicity causing vertigo, particularly gentamicin would be the aminoglycoside that we use the most in clinical practice. However, if it was systemic gentamicin administration, so intravenous, then you would expect it to be a bilateral vestibulopathy. So usually the patient may have disequilibrium and oscillopsia rather than a vertigo per se, because it's a bilateral problem and the two either seem to balance each other out. Conversely, if it was locally administered gentamicin, so if there were ear drops, gentamicin-containing ear drops used for the treatment of otitis externa or otitis media, and if they were inappropriately prescribed to a patient who did not have an intact tympanic membrane, and the gentamicin was therefore able to get through the tympanic membrane into the middle ear structures and then find its way into the inner ear structures, then that could be a cause of a unilateral aminoglycoside toxicity causing a unilateral vestibulopathy, and then the patient certainly could have nasty vertigo. Then otitis media, of course, that's not rare. That's a very, very common condition, but that can certainly cause vertigo and disequilibrium. But the pain and the discharge and the fevers should be a giveaway for that diagnosis. Now, there are described cases in the literature of epileptic vertigo, but I will say it's very rare, very, very, very rare for epilepsy to cause isolated vertigo as the only symptom. So this year, whilst working in a comprehensive epilepsy service in a seizure investigation unit, there have been some patients who I've seen and admitted and treated who have had vertigo that has been a part of their focal aura in their drug-resistant focal epilepsies, and sometimes it can be the initial symptom, and it can be arising from different brain areas. It can be the lateral temporal structures, mesial temporal structures, some other structures as well. But I haven't seen a case which has manifested with isolated vertigo and nothing at all else. So if you see a patient who just has an isolated episodic vertigo, it probably is not going to be an epileptic vertigo, although it is described in the literature as a potential cause. Then symptomatic Chiari malformations could be a cause of vertigo, and that may be precipitated in the context of neck extension in particular, and that should be accompanied by headaches, neck aches. It may be accompanied with long tract signs, possibly other lower brainstem signs. Demyelination can be a cause of vertigo. We already mentioned the case of MS and a demyelinating plaque in the brainstem. Posterior fossa mass lesions. Episodic ataxia type 2 is a cause of vertigo and disequilibrium, and that responds to acetazolamide. And then there's this condition called disembarkment syndrome. So that's when someone returns to the ground after they've had a period of passive motion, usually water travel, but sometimes air or land travel, or sometimes time spent in flight simulators or on water beds, and then you get off the boat or you get off the plane or you get off your waterbed or your flight simulator and you stand on solid ground again, and then you have this disembarkment syndrome where you have this vertigo. But usually the history should give that away. And then the last thing I'd like to talk about is a bit different. So far we've mostly been talking about acute vertigos, with some exceptions. I did mention a vestibular schwannoma earlier, but for the most part we've been talking about acute vertigos. What about the patient who just has chronic persistent vertigo? One condition to think of in that case is called PPPD. So not BPPV, it's PPPD. And that stands for persistent postural perceptual dizziness. And so PPPD, persistent postural perceptual dizziness, can be provoked by static images. So, for example, a patterned carpet or moving images. It manifests often with a constant type of dizziness, and it's sometimes seen in the general neurology clinic or the neuro-otology clinic as an after effect of some other form of vertiginous disorder. So maybe the patient had BPPV and then they were treated for their BPPV and the classic BPPV symptoms abated, but then they have this more chronic, persistent vertigo, which is a residual symptom after that initial treatment and disease phase. And that might actually be that it's now evolved more into a PPPD presentation. And there is a functional, or there's thought to be a functional component to the pathophysiology and the symptomatology of PPPD, kind of in the way that there's thought to be a functional component to IBS and some other conditions. And the management for PPPD is non-pharmacological, and it may be helpful to refer the patient to a vestibular physiotherapist, for instance. So that's all I had for today. Thank you so much for tuning in. If you enjoyed the episode, please like, comment, and subscribe because it really helps the project. Visit our website at rneurologyeducation.org. That's R for the letter R for all of our media formats and additional content. Find our videos on YouTube and our audio podcasts wherever you listen to your podcasts, and join us on your preferred social media platforms, all found at the domain at rneurologyeducation. And email us on contact@rneurologyeducation.org with any questions that you might have, or to subscribe for updates for future content releases. From cortex to curiosity, this has been Restored Neurology Education. Until next time, keep calm and synapse on.